Welcome to my channel, Conversations with Dr. Sue. I am Dr. Susan Musicant, counseling psychologist and author. And today we are very privileged to have Dr. Shelley Kibel in conversation with me about the honor and horror of caring for a terminally ill loved one. And what we hope is that our conversation will help 1 or 10 or 100,000 of our audience, just with something that we've said that makes this journey easier. Shelley, thank you so much for joining me today in this, which I hope will be a very helpful conversation for anybody who is caring for a loved one who's terminally ill. Shelley is a palliative care doctor who has worked in the field for 15 years. So what I wanted to start with is to ask you, in your many, many years of experience, what you have seen with people who are caring for a loved one who's terminally ill. In other words, what stressors do you see with those close?
In palliative care, I think for me, one of the most important things is to help people feel safe. Because this is a stage when everything becomes uncertain. All of your frame of reference falls away in many, many cases. People don't know what they're negotiating. Most people haven't walked that journey previously. So, and if they have, then they sometimes stuck on what they expect, and meanwhile, every person is different.
Is that
every
uncertainty?
Situation is
Yes.
Yeah. Yes. So it's really an opportunity to learn about uncertainty, living with uncertainties, and which in our culture we don't really do much of. We like to try and get things
have control.
In control, yes, exactly.
And is you talking about the uncertainty of the patient who's terminally ill, and I'm also talking about the uncertainty of the person taking responsibility for that person. What's happening? What about tomorrow? Do they need to be at home? What do we need to do in areas that we have no education about?
Quite right. Yeah, it's on both sides, because in that situation also we can't separate out a patient from a family. We see a family system. Yes. As societal or community system sometimes. Yes. But the person who is ill becomes the central part of that. But you need to try find a way to make everyone in that little space feel safe and understand what's happening. So the first step really is the understanding, I think, which is so helping clarify what is going on. Already makes a huge difference to people. Very often people who've been ill have been in and out of hospital. They've been going from one doctor to the other doctor. They're just overwhelmed with information or lack of information, basically, often. And so no one quite knows what is happening usually. So the first step really is to try and simplify and clarify what's happening in a language that people can understand.
So when I asked you to join me in this conversation, and I said that I really wanted us to shine a light on the people who are taking responsibility for the terminally ill loved one. And your comment to me at that time was, I didn't really think about that, and I will give it some thought. Mm-hmm. But in fact, it's exactly what you did for the patients that you've seen who are also patients, clients of mine. You've helped them to breathe better by coming into the system and helping them to define where they are in this incredibly uncertain time. And that gives such safety, security, that you're there. The other thing that I don't know about your other people, but I think you do know very much about boundaries. You very much respect the patient's boundaries and the family's boundaries. It's not what you say, it's what you don't say, and your energy in that process. That is a support that's so helpful. You don't come too close physically. You don't come in and hug. I mean, I hugged you at the door because I'm so grateful that you're here. But you don't come into the system and step on anybody's toes. You're respectful, but caring and warm and safe.
You know, to help people feel safe, you have to read where they are at. You know, some people love a big hug and you need it. During COVID, we could not hug at all. And it was hard for some people. You know, I am generally a little bit more reserved. We have to, you take however you know, your own authenticity and your own way of behaving is important. But at the same time, I think it's helpful to help families understand those boundaries, because some families have no boundaries, and they sometimes make it harder for a patient. Very often I'm having to say to people, just give the patient a little more space. You know, even though they want you there and it's lovely that you're there, they also need time, especially when it comes very close to dying. People very often just need to be alone, and so often people die at night when immediate family are not around.
It's almost on purpose.
Yeah, it's because in some ways it's easier
to die, to say goodbye, to just go quietly.
Yeah.
That's very interesting. Is that also because the person who's so ill at some level doesn't want those close to be with them when they die because they're worried they'll upset them?
Well, I think that's a big part of it. I mean, you know, the process of dying is so mysterious. One can never really be categorical about anything. But the way I've understood it is that it's a process of letting go. And to let go of people you've loved is really hard, you know, in life. So why shouldn't it be hard in death? So death is a process of letting go, and you know, it's hard for loved ones, for family members to realize this is that part of the journey you can't do for your loved one. They've got to do it alone. And so it can cause pain on both sides.
You need to read the situation. You need to read the room. You need to read the system to know how close to go. Is a hug appropriate, or do I need to do my usual little bit more reserved, hold back a little bit and just be understanding and clarify with words? I think the fact that you read the room so well is hugely comforting for the caregiver and my clients and for the patient.
My approach really is just one of gentleness and respect. It, you know, I think that gets through to most people. There are some people that need a different kind of style, or something a little bit firmer, or a little bit firmer, or there in many ways, and they might need, you know, a totally different approach. And that's why obviously there's an individual connection that has to happen. It's having this balance of compassion and detachment. It's detachment. People often think compassion is you've got to just smother people, but that's actually not. You can sometimes give much truer, clearer compassion if you are holding back a little bit and being able to observe, respecting the space, because it is the space. I like that actually. It's the space between people where the magic happens in a way.
It's true. I never thought of it that way. It's space to breathe. And I think that's what the carer and the patient so badly need.
Everyone needs that.
I remember also on quite a number of occasions where family members have wanted or needed their loved one to either survive longer, to have treatment that the person doesn't really want, or to have some kind of spiritual input that the person in the system needs for the patient.
Yes.
And it's quite an interesting negotiation and a sensitive one also. What do you do when the patient is not so keen to go ahead, for example, if they've got cancer with chemo and radiation? They've been told that their cancer has metastasized, and they can have a little bit more runway, but they know that there are going to be a lot of side effects, ill effects from the treatment. Where do you come in? How are you between the caregiver and the patient when it comes to that?
I think the basic principle is really that it is the patient, and sometimes families need to be reminded about that. But in our system, we do try to put the patients as the center, and the patient's sense of autonomy as the center. So if a person is still of sound mind and is able to make those decisions, they need to be empowered to make those decisions.
And you would explain to the family.
So it's explaining in language that people understand, and also trying to get the facts.
So in working with many clients who've either themselves been going through terminal illness, or with people whose families or a loved one is, and having had quite a few people close to me getting ill and passing away, very close people over the years, I termed our conversation, as I said earlier, the honor and the horror of being close to somebody who's terminally ill. And I think what we're talking about is the honor.
Yeah.
It's a proper honor.
Yes.
That somebody, even with respect for the space between us and between the palliative care doctor, if we're fortunate enough to have one, is that feeling of, I don't know if I can call it pure love. It's uncomplicated, it's undefended. We don't have to put our defenses up when we're close to somebody who's dying. We don't know, we can't give the person reassurance that everything will be fine. Because we can't, because we don't know.
That is something that causes people a lot of stress, is this unknown, the timing, because we like to know time. And in this modern age, when we've got family all over the world, their timing becomes quite a crucial factor.
They've got to make plans.
Yeah. So it's a practical thing as well as just an emotional thing. But at the same time, we are dealing with this mystery. We really don't know. So, but obviously, with experience, your health professionals need to advise you as best as they can. There are certain parameters that you watch and see, so you can get a sense of the pace of the change and the sense, and that way you can predict to a certain degree, but also letting go the actual absolute nitty-gritty 2:00 business. Same as people having babies these days. People don't like to wait.
No, they want a Caesar.
Yeah, so they want to know the date and time.
Yes.
And it doesn't work that way.
This
naturally.
Whole process of coming face to face with people going through this, and myself too, has taught me about not planning too far in advance about anything. And I've read a little more about, because I wanted to know what other people feel besides my clients. And there's been a fair bit written about the people feeling anxious, the people caring for the terminally ill, feeling high levels of anxiety with the uncertainty which you spoke about, having depressed mood, and I wondered if that was also something that was sitting with the carer before, and also absolute exhaustion is another thing, with or without other carers, because one feels like you always on guard. You can't totally relax because something can happen, whether you're at work or you're sleeping. You'll be on guard and the adrenaline is pumping and doesn't go away. Is this what you...
Yeah, exhaustion is very important part, I think. So I'm always telling people to try and get sleep, have a break, take it in turns, because very often families will want to be together all the time. Some families, that works for them. They energize each other and they love that. But it is because of that sense of giving the patient space also, it's fine to go have a break. And it's very, very, because some people feel guilty if they're taking off a moment.
100%.
So that they sometimes need encouragement to just go out for a walk or do whatever they need to do, go to the hairdresser.
This is something that I found helpful and that I prescribe, is the person who's the chief carer to take a break and to ask somebody who the patient feels comfortable with to sit in. Giving space, sit in another room if need be. But number one, the patient needs to feel comfortable with that person. And secondly, the person who's caring for the patient needs to get out, breathe other air, see other people who are not on their last, and go and have something light in their lives.
And to be reminded that there's a world out there,
that there's
because
life.
It can be very intense.
I had another question, and I don't know how much you've seen it, but I've seen it on occasion, is where the person caring for the patient now has a purpose, and a very strong purpose. And this is their life and this is their purpose, to see to every symptom and this process in the loved one's life. And then the person passes away and their purpose is gone. I don't know how much you've seen this.
Well, I don't follow up that closely with patients afterwards, because it's too impossible to manage everyone, even though sometimes check in. But I recognize what you're saying, and I always try, if I pick that up in advance, I will try to prepare people, and I will always make sure that we offer bereavement support afterwards. And sometimes, I'll reiterate that a few times if I can see that there's likely to be a problem. But caring for others is a very special thing, and I find it fascinating that there's always at least one person, a central person, that rises to that challenge. Even in families where there's and even in families where people who've got no families, there'll be a friend or some person, even someone who doesn't know them well, will just suddenly slot into
stand up.
And I find that really fascinating. It gives me hope for humanity, because there are people who really truly get true pleasure and from giving to other people. And they need to be nurtured.
We're talking about the central person in the patient's life, which may be a relative or sometimes not. But how much have you found that person who's offering care, sometimes practical help, sometimes where other paid carers are not part of the affordability, that caring person who stands up and does over and beyond has a very strong spiritual faith, whether that be of a religious nature or other. because I've often found that somebody who has a strong faith is a giver, more a giver than a taker, and want to give in the community or to a special neighbor or a special friend or a stranger. It's Do you find that faith comes into this picture?
Again, it depends on what you mean by faith, but I think many broadly. of us, many people who work in this field do have very strong faith, because people see it as a calling, really. People say, why? How do you work with it? How do you do this type of work? A lot of people will just walk away from me as soon as they hear what I do, because people don't want to think about this aspect of life.
No.
So more and more the world is changing a little bit, and people are bringing in these discussions, and people are wanting to choose and know that, start accepting again that the natural phenomenon that we all going to die at some point.
What drew you to do this? I thought you have to have lost somebody close, and you said, no, I think it's a calling.
Well, many people do go into this work because of having had some major loss.
Yes.
I've been very privileged and fortunate in my life to not have had, serious loss, which is, I think, also helped me deal with the work, because you do need a certain detachment. You can't get too emotional about everything. But in your psychological work, that's the case too. You can't get drawn into people's emotions. So you can hear people, listen to people, but you do need
keep
to
a boundary,
keep a space. In some African cultures, they actually don't see the patient as the center of the situation. As soon as a person is ill, they delegate the responsibility to the elder in their community, and the community as a whole has to speak for this patient. So a fascinating book written by a Rwandan doctor who describes the different family dynamics. But that's it. But you have, I have also worked a lot in underprivileged communities where people don't have the resources to employ people. Yes. And it just amazes me of the strength that people have, and that they don't have another option but to keep someone at home, and they do it with so much love, and it becomes so much part of their family's story. So the children grow up seeing that death is part of the normal happening, part of life, and everyone does a little bit. So they share out, and very often in those communities, the faith community, the church community, will step up also, and they'll bring a huge amount of practical support in as well.
And food. Meals and food. And so in essence, you have to have seen hugely more than I've seen in my lifetime. You've seen, this is your work, and you do it with such grace. And I thank you for that, and for what you offer to people in our community, in the underprivileged community in general, just by your presence, what you say and what you don't say. And it sounds like what you've seen is life at its hardest and worst, and at its best. You see the authenticity of life, and you offer on your side the support. You make suggestions that are very practical when you've read a room. On my side, I really, because my area is managing stress and depression with adults, and one of the first stress managers is space. Taking space, because it's like oxygen, without guilt. Saying no to unreasonable requests and letting the guilt go. Taking time out and seeing, like what you called, life on the outside, I think is hugely important. And guiding people in a direction after they've lost somebody close, if they want to, if they need to talk, and never forcing somebody to anything. I think you work in that way. I work in that way. You respect that people need to have agency over what they do and their gut.
Sure.
But those
ambivalent... to acknowledge that feeling. Very often people have to
yeah.
care for people that they don't love.
And
it's still quite amazing what they will do that still.
Yes.
And process it all. But I just wanted to come back a bit to the practical side of it, because you mentioned that advanced health directive, or living will, as we call it.
Yes.
That's a very good way to have to open the discussion of planning for the future.
Yes.
Because so we've been discussing a lot of the emotional side, and you are a psychologist, so of course we need that side, and it's hugely important.
But I'm a practical psychologist
too. Good. And I'm a practical doctor too. So I think the emotional side and the spiritual side are hugely important.
Right.
But when it comes to actually looking after someone who is ill, the practical side often takes precedence. It's completely dominating in many situations, because nursing is a very hands-on business, and it's an exhausting business.
Yes.
So that's where, if you know the time frame, it does help to a certain degree, because you don't know how long it's going to go on for. But if you look at the simple ways that life can be made a little easier. So one simple way, well, it's actually maybe not so simple, is that discussion about the Advanced Health Directive.
Yes.
That is a simple tool to help the family and the caregivers understand the patient's wishes. And that lifts a huge burden in the future, because everyone's thinking, do I, don't I, do I, don't I? If you know
shouldn't I? Do I feel guilty if we hold back on treatment? But this is what the person has expressed that they wanted.
So that is one way that's very important. And then also to think completely practically about finances. Make sure, obviously, it sounds obvious, but it's funny how many times people don't do it. They don't sort their wills out.
Yes.
And very often at the last minute, people are trying to sign little changes to their will or whatever, which causes enormous stress. So I always advise people to get the practical stuff done as quickly as possible. And that includes power of attorney, passwords, making sure that someone's got your passwords.
Yes.
So those are very small things, but they are huge things. Sometimes they involve a lot of work.
They have been things that have been brought to my attention with other people and with myself. And there might be a checklist of those kinds of things, because something you mentioned now, power of attorney. Who does the patient want to have power of attorney? And it's more complicated than it was, for example, many years ago when I lost my mum. It was simple. It was a letter, and you signed and I signed, and it was done. Today there's so many things.
Yeah, well, especially when it comes to banks and finances, because a general power of attorney doesn't hold.
And it used to, and it doesn't.
So the banks often they will insist on someone coming into the bank.
Oh my goodness.
And I mean, I write letters and try and reverse it. Some banks are more accommodating than others. They'll sometimes send someone over to the house.
Right.
But if you haven't done that and got that power of attorney, you can land up with a really complicated financial mess to sort out.
And then, whilst the person is still alive but not strong, there's so many expenses to pay.
Yes.
And this is difficult.
And that's hugely anxiety provoking for people.
Yes. So it's good if, do you know what I like to do? If the person who's the patient is not as ill yet, with respect, I like to talk to them or talk to the family member and say, look, I don't know what's going to happen, or even if you're going to die. We're all going to die, but you don't know exactly when. Whilst you have the strength, it's a good idea to put your affairs in order. And I would say, this is what I've done, so that I know that I'm not going to give my family more anxiety than they need, should I not be able to manage this.
Yes.
And then give them perhaps, I mean, even as I'm thinking, to make a checklist.
Sure. Yeah, and create a letter of wishes. So that
A letter of wishes.
So many people are encouraging this. I know financial advisors encourage it too, to just talk to people, to encourage people who are healthy to actually get their affairs in order.
Very good idea.
Don't leave it to the last minute. It's a nightmare.
Yeah.
I mean, I've had patients, family members too, who've died suddenly, and then someone has to pick up the pieces and sort things out. And that is, it's massively time consuming and massively complicated if they haven't put everything in clear packages.
I have a little bit of, I think it's a funny story about that. About once a year, I pull pieces of my life together and I put it into a letter. And it's a letter of wishes, and it's a letter where everything is, because it's complicated. And the last time that I did this, I told one of my adult sons that I've just put this letter together and I want you to know that it's in such and such an easily accessible place. And it spells out where everything is, and the keys and the bank and the this and the that. He says, "Ma, are you expecting to go anywhere soon?" I said, "No, I'm not expecting to go anywhere, but just that you know." They hate me to talk like that, but I talk like that anyway.
Well, that's you, very wise, really. And it is
that they
one day they will thank you for it, even if it's harder for younger people to take this on board. But the longer you live, you realize how important it is.
Yes.
Yeah. And so thinking back to what other practical things there are, just having the right equipment around the house to help, just so get advice if you don't know about things like that.
Also, you're talking about the bathroom and things to hold on to. And even when one doesn't have ill people in your home, when you've had a handle next in the shower or next to the toilet, such a help. Such a help. Or if you need a bed, a hospital bed, and you have the ability to get hold of one, it makes life for the patient and the carer that much easier.
Hospital beds sometimes are not person's preference, but they certainly help the caregivers a lot, because especially if a person can't move themselves and they need to be turned and cleaned.
So it depends.
Yes, so it does depend. And certainly it's not, having a hospital bed is not one of the essentials on my list.
The last thing I wanted to say, which I think we have sort of said, is what does the patient want in terms of boundary of others? Because it feels like there are people around, or often people around, who want to come for a visit and come and have tea and come and chat, and the patient is tired. And it's on a practical level to tell the person to limit the visit. It's time to go now. To not be shy, to tell the person to scoot in a nice way.
Well, again, it's very individual, but because there are some families and some cultures where it is just completely against the grain to push people away. People are especially if they're well known in the community, even if they're not, people have to come and pay their respects. But from my side, I'm always trying to empower people to say, listen, again, if the patient is tired, the patient must set the limits. And sometimes there has to be someone appointed as the gatekeeper. To say, okay, he's had 3 visitors now, it's enough time to go. If you come, please stay 5 minutes. And set those boundaries up nice and clear.
You've got to be culture sensitive, but find a balance also between the culture sensitive and politely assertive.
Yes, yeah, because some, you know, it brings up another point here. Often in this situation is sometimes roles get very reversed. You know, the person who's dying might be the main decision maker,
Okay.
and the person who's looking after them suddenly has to step up to making those decisions, which they're not used to, and it can be very challenging and anxiety provoking. But sometimes they will involve another family member, you know, older or
an elder,
who can be an elder, you know, to assist them.
Yes.
But sometimes they've just got to find that strength in themselves to say, because it could be a young daughter who suddenly then has to
step up.
Yeah. So you try and empower them to say, look after themselves and also set those boundaries.
So I think today we've looked quite deeply at the emotional, social, and some of the practicalities. But even if we haven't covered everything, my hope and my wish is that we will trigger something for anybody, one person. I always say, if it touches one person or 10 people or 100,000 people, that somebody says, aha, that's what I can do, or that's what I will do in the future, then I'm happy. Thank you so much, Shelley.
Thank you.
It's been a privilege.
Thank you so much, Sue.